Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Mr. Chairman, thank you very much for the kind introduction, and I thank the Society for Cardiac Surgery, for the Gulf Society of Cardiac Surgery, for this opportunity to present alongside giants in the field. So without further ado, I shall start. I have nothing to disclose prior to this, although I might be advertising AtriClip a lot, but they are not paying me enough or nothing at all. So my outline will be introduction, risks, and this I will explain in the studies part, the types of occlusion, the current guidelines, and I shall conclude. So basically, we all know that stroke currently is the third leading cause of death in Western countries. We saw that in the previous lectures as part of the cardiovascular burden. In 20% of these strokes, atrial fibrillation is indeed involved. And as we all know that atrial fibrillation is as high as 20% over people over 65 years of age. And we heard today that our population alongside international populations are getting older. So this burden is going to be higher in the future. There have been studies that has proven that in most cases, the left atrial appendage is the source, as high as 90% of cases. Now, there are other studies also that has shown that cerebral ischemia associated with cardioembolic stroke is much more serious than the ones with non-cardioembolic nature. Left atrial occlusion rates in the recent time have risen dramatically. And this is because in the first, when it was used, such in MACE 3 by Cox, it has shown that indeed there is a significant reduction of stroke. Now, we all know as surgeons, the left atrial appendage is a variable shaped part of the left atrium. Its function was not known until recently. Recent studies have shown an association with the transportation and hormone secretion of natriuretic peptide. And in patients, as I mentioned, with atrial fibrillation, 90% of the thrombi, they origin from the left atrial appendage. Types of occlusion, of course, we have surgical, and then we have interventional. Surgical occlusion can be through suturing or stapling. It could be through excision of the left atrial appendage, such as we did with the MACE 3, or it could be clip occlusion, which is becoming very popular, and a picture on the right-hand side. Percutaneous approaches, it could be a Watchman device, it could be an emplaster device, and so it is basically a device that is inserted percutaneously without opening the chest. Now, what are the data about this? And I bring you this phenomenal study from Whitlock and his group that was published in the New England Journal of Medicine. It is the type A evidence that you want. It's a randomized, controlled study, multi-center. It had 5,000 patients divided equally. It was semi-blinded, and they followed it for almost 4 years. What did they find? Basically, when we talk about the inclusion criteria, they have included patients with atrial fibrillation that had CHAD score of more than 2. What is CHAD score? CHAD score is, as you could see in this table, it is additional risk factors for people who have atrial fibrillation, such as chronic heart failure, hypertension, age. Age now has 2 points. So there is age above 65, and then age above 75. So if you are above 75, you get 2 points. The results, the types, I put the slide first, what types of occlusion they have done, and you could see the cut and sew was 55%, the stapler 11%, and then other closure devices 15%. This is the result. What did they show? They showed a cumulative incidence of stroke or arterial embolization reduction in these patients over the period of the study, which was 4 years. And as you could see, this difference is growing in time. Initially, it was the same, but then, as you could see, that this burden was taken away from patients, the risks have become less. Now, if you look at this subgroup analysis, in each particular subset of those patients, occlusion was better. If you're talking about gender, age, rheumatic, other types of risk factors, any other valvular problems, occlusion did better. When we talk about, and this is what I alluded to in my initial slide about the function of the with the left atrial appendage, because I heard Tyrone David talking in lectures and saying, you should not remove the left atrium. It has a function. God made it for a reason. And we are worried that when we remove it, it might cause heart failure to patients. Randomized control studies said no. They did not observe an increase in hospitalization for heart failure, either early or long. If we dissect the results, we look at the primary outcomes, ischemic stroke, significantly reduced. So, with regards to ischemic stroke or ischemic stroke and systemic embolization, significantly better. What are we worried about when you put in a device like this? So we worry about heart failure, we worry about major bleeding, or we worry about myocardial infarction, just in case you took a stitch too deep or you applied the clip too close. But no, in this randomized control study, there was none. What about bypass time, cross-clamp time? Nope, no difference. What about bleeding? Did we have? Nope, no difference. No reoperation for bleeding, no prolongation of stay. So occlusion is safe and works, but which type? In this study, they showed any type that I can use, but I can dive into that further. Comes the atrial clip, which is a device that provides a mechanical occlusion, and this has been studied through 180 days, and it was confirmed there was lack of communication and clip stability, and it was studied for migration, and there was very little migration on 180 days, and it was studied even for electrical isolation, and studies have confirmed that that distal to the clip there was no electrical conduction. It is MRI safe, provided you follow the company's guidelines of using 1 Tesla MRI, and the long-term effect on cardiac function was not negative in any way. So, and this was, this came about through the FDA approval trial. So this is basically, it's equivalent to a phase 1 trial. So it was a prospective, non-randomized for 70 patients who went for open chest surgery, and it was multi-center. And in this study, they defined complete exclusion by means of contrast-enhanced cardiac CT, 3 months post-surgery. Their inclusion criteria were any patient older than 18, subject had any one of the following risk factors, such as a CHAD score of more than 2, age more than 75, hypertension and age, history of atrial fibrillation, and previous stroke. So those are the patients. Look at the right. Only half of them, more than half of them did not have atrial fibrillation. Why? Because it's a phase 1 trial. So basically we are looking for the safety of the device. The endpoints, they looked at the operative LAA tears, tissue injury, bleeding, or others, and there was none in these selected group. They have published that 70 out of 70 clips were successfully implanted, and in 69 patients, they had complete exclusion by intraoperative TEE, and they had complete exclusion in 60 out of 61. So basically, on that one person, they had 2 clips. And that was confirmed on CT scan at 3 months. So there was no device or clip-related procedure in this study. and no evidence of clip migration on any CT evaluation. So what are the guidelines? So the current guidelines state, and this is the European Society of Cardiology 2024 fresh, and it says surgical closure of the left atrial appendage is recommended as an adjunct, and this also was in that study. It's an adjunct to oral anticoagulation, not a replacement, to prevent ischemic stroke and thromboembolism, and that was a class 1 recommendation with a level B evidence. Surgical closure of the left atrial appendage should be considered as an adjunct to oral anticoagulation in patients with AF undergoing now just endoscopic or hybrid, and this is a 2A recommendation with class C evidence. Standalone endoscopic or surgical closure of the left atrium is still a class 2B recommendation with the level of evidence C. So I conclude that left atrial appendage closure or occlusion has been studied and has proven its safety. And studies have consistently demonstrated that it is a safe procedure when it's done during open heart surgery, potentially may significantly reduce the risk of stroke and embolic events in appropriately selected patients. Definitely there is a knowledge gap about the cost effectiveness, and further research needs to be done. And our decision to treat this should be a patient-centered decision, and the choice to include the left atrial occlusion should be tailored to individual patient circumstances and discussed within the surgical care team. My advice to you that evaluate the evidence that's out there, weigh the risks and benefits to determine what is best for your patient. Now you say, Alblooshi, you did not provide any level A evidence on non-AFib. I tell you, don't fear. There is a study. There is a study that's going to come out. When? I don't know. So very little about it. But in this study, it's going to be a randomized control study, and it's going to look at all patients, even without atrial fibrillation, with occluding the left atrial appendage. I put this image because I asked ChatGPT to give me a picture of a left atrial occlusion, left atrial appendage occlusion, and just to make you at relief. Artificial intelligence will not take our jobs as cardiac surgeons. I don't know about cardiology though, I'm sorry. So with that, sir, I conclude my talk. Thank you very much.